about progression of atrophy in a myopic patient over time.
Thank you. Thank you for asking me to present on this very important topic on development and progression of atrophy in high myopia. As we know that myopia has many complications associated, but one of the most important is retinal disease. Among these, development of atrophy. And atrophy may be diffuse or patchy, and there could be other factors beside staphyloma or associated with the staphyloma responsible for this patchy atrophy. One of these is development of lacquer cracks, and we recently demonstrated that lacquer cracks may be developing because of presence of perforating scleral vessels, and this is probably one of the reasons for the previous question. So why some eyes may develop atrophy or new vessels while they have the same axial length or same magnitude of staphyloma. So this could be related somehow to the position of these perforating scleral vessels. And these scleral vessels actually are also associated with development of neovascularization. So that there could be something in the sclera besides staphyloma responsible for such complication like atrophy development and neovascularization. Another important cause for development of atrophy is still associated with lacquer cracks and is presence of bleeding. But bleeding could be simple bleeding because of lacquer cracks or related to development of a choroidal neovascularization. Distinguishing between these two is extremely important because the approach is completely different. If we have new vessels with macular hemorrhage, we have to treat with anti-VEGF. While we have a simple bleeding, we just have to watch without treatment. And the gold standard for make differential diagnosis is FA, so fluorescein angiography, but also OCT angiography. So we wanted to, as we are doing less and less fluorescein angiography, and it's not always that easy to make proper interpretation for OCT angiography, and OCT angiography is still not available in all offices and hospitals. We were looking for a biomarker with a more simple imaging modality, that is structural OCT, for distinguishing between simple bleeding and bleeding related to choroidal neovascularization. This is the binary reflective sign, that is this hyporeflectivity, this linear hyporeflectivity between the hyperreflectivity of the RPE and the hemorrhage that is typical for simple bleeding, and that is not as much present in bleeding related to neovascularization. This is in our study. This was then further demonstrated by following up these patients without treatment with complete resolution. This is face-to-face cases of simple bleeding and bleeding related to neovascularization. You can see that there's no line here, hyporeflective line here. And again, with multimodal imaging together, putting together FA and OCT angiography, we had the confirmation for all cases that this is the absence of the binary sign is related to presence of new vessels. And this is the binary sign instead in a case without new vessels. Again, FA and OCT angiography demonstrated the absence of new vessels, but still the beautiful binary sign is clearly detectable here. This is very close to 100% sensitivity and specificity, so we can distinguish between simple bleeding and bleeding from CNV with just a structural OCT, looking at this highly reliable OCT sign. And then we applied a quite complicated analysis with artificial intelligence to further demonstrate that the binary sign is trustable. And I will go quickly through the results, again, without including our definition of binary sign and the artificial intelligence. We were able to demonstrate that artificial intelligence detected the same finding as the key feature for making the differential diagnosis from simple bleeding and bleeding related to CNV. And this was recently published in EURETINA, while the binary sign on subjective analysis was just accepted in the eye journal. So now we move simple bleeding, CNV. They both are responsible for development of atrophy in pathologic myopia. And one question is, what about progression? So when we have atrophy, this may progress spontaneously, and then when this atrophy is associated with CNV, and we have to treat with anti-VEGF, is that associated with a higher progression of atrophy? Well, we did this kind of analysis, so we looked at both eyes, so patients with atrophy in one eye and the fellow eye with atrophy associated with CNV that needed anti-VEGF treatment. And the results were highlighting that while there is an increase over time of atrophy at the level of CNV, and this was associated with anti-VEGF treatment. On the other hand, the areas of atrophy that were besides the CNV and the atrophic atrophy, the areas of the fellow eye that was not treated with anti-VEGF, well, they progressed but in a similar manner. So there was no impact of anti-VEGF beside the area of the CNV when we look at the patchy atrophy that are outside the area of CNV. Still, with a progression over time that is probably related to natural history, and this was a few years ago published in the IOVS. So in conclusion, now we have very useful tool, but also very simple tools, imaging tools may help us distinguishing between the causes for development of atrophy and their progression. And we are happy to know that the anti-VEGF have no impact on patchy areas outside the area of CNV. And thank you very much for the attention.
Thank you, Giuseppe, for this beautiful presentation. By the way, if you have questions, you can submit in the system, in the application, or you can come to one of the microphones and ask your questions. Any question from the panel, or Caroline, do you have a question?
No, thank you for the beautiful talk. So I did wonder about these scleral vessels. Do you think they are pre-existent and then that's where the CNV comes, or do you think it's like secondary and it moves around?
Yeah, they are pre-existing, and their location is probably related to a high movement. So because of the high movement and the relationship with the optic nerve, they are causing probably some further stress to a already thin choroid and Bruch's membrane, and this is probably causing development of hemorrhages, lacquer cracks and hemorrhages, for example. And this probably may be one of the causes I said before that may help to understand the differences between those eyes that may develop a complication when they have same axial length and same entity of staphyloma. So probably just a matter, all of us have scleral vessels, but probably it's just a matter of where they are located. Thank you.
Giuseppe, I have short question, we have time. One of the questions that often comes when we do study on myopic CNVs is that how to be sure at the end that the diagnostics were right. Because the hemorrhage disappear, even if you don't see big stuff there. It may have been in your vessels that involve or didn't increase. So how do you ensure, what's your technique? Because you use the AI, you have this very good presentation on the science. So how did you ensure the diagnosis?
Yeah, we don't have data on artificial intelligence in that sense, on making proper diagnosis of recurrences or develop. Well, development is not that difficult, but the main problem is recurrences, because We all know that there's not much exudation, and the exudation in general is not that hyperreflective, but rather hyperreflective. So I would say that my first diagnosis is done with patient symptoms, and then imaging, as many imaging I can do in this kind of patient may help. Probably still the gold standard. Beside all papers that have been published looking at OCT and geography, I mean, we don't have signs of demonstration of reactivation, so I still trust in FA in these patients.
Thank you very much, Giuseppe. Excellent. So the next presentation by Josh Jonas on another big problem in myopic, which is the neuropathy.